Welcome to A Window on SAMRI, where we take you inside South Australia's independent not-for-profit health and medical research institute. Each episode, we get to know the people driving our life-changing research, getting into what motivates them personally and how their work is delivering a brighter, healthier future for all.
So, Chris, what got you interested in science?
I think I had a pretty early interest in science, even in high school. I found chemistry and physics quite interesting, and I generally got good grades doing those subjects. Interestingly, I didn't actually do any biology in high school after year 10, but I think doing the chemistry and the physics really drove me down a path that science would be at the core of what I do. And I guess when I was thinking about what career I want to do after high school, I knew I wanted to get into the medical field. It was just a matter of what type of career I was actually looking for. But I really found an interest in working in a laboratory, again, from the early chemistry and physics days, and doing experiments and using Bunsen burners and chemical reactions in the laboratory.
So the stereotypical science is what won you over.
Yeah. It was really
blowing stuff up.
I didn't, but I did. My year 11 and 12 chemistry teacher definitely did blow a few things up.
As every good chemistry teacher should.
Correct. And I think that was actually part of the fun, even though probably at the time it was maybe a little bit dangerous and wouldn't be allowed now. But it was actually, I think sparking that, enthusiasm, not only just in high school level, but primary school level, but sparking that interest in I wonder what's going to happen now.
Yeah, science definitely could stand out in that respect. It was a bit more obviously exciting than English literature and maths apps or whatever you were doing.
And I did maths and English as well. And
were you way better at science? Was it like pretty obvious, or
not necessarily? I think I did fairly evenly across all my subjects, but I think just a bit of the more hands-on approach that the sciences kind of tend to involve is what got me hooked.
Does science run in your family?
No, not at all. Not at all.
Okay, so none of your family really understood you.
No. So my dad was a teacher for a long period of time.
Not a science teacher.
Not a science teacher. No, he was actually a tech studies teacher. So again, quite hands-on.
Good with his hands, yeah.
Yeah. So that was a lot of, the early, formulation of my mind was, just doing stuff.
Yeah.
Computers weren't really a big thing, back then. I mean, you used them, but nothing more than, basic word processing or, maybe some, early versions of, game consoles and things like that.
We're talking back in the 70s?
Oh, no, I'm not that old. But definitely in the late 80s, or mid to late 80s.
Yeah, they've taken off 90s. A bit since then.
They have, but, I would argue that they got nothing on those original ones. So, yeah.
The original and the best.
That's right. But no one who I've really followed in terms of being a scientist in that respect. Certainly, we have a bit of a family association with health and health care. My wife's a nurse as well, so that I think complements probably what I do quite well as well, because she obviously deals with the other spectrum of healthcare, where you actually delivering care to patients on a day-to-day real-world basis, whereas we're, as researchers, trying to ultimately have that impact down the track by translating what we do.
So what path did you follow at uni and beyond?
Actually, I originally started as a doing a degree which was called equivalent of biomedical science, but more focused towards being in a more of a routine diagnostic laboratory setting as my undergraduate studies. There were some research components to that, but essentially we'd spent so many hours doing, pracs, using pipettes, growing bacterial cultures, studying blood cells, all the stuff that
people think is science.
People think is science.
Yeah. And did that suit you?
Yeah, I really enjoyed it. It was really good. It took me a little while to get used to being back in a biology aspect. As I said, I didn't really do it in year 11 and 12, but at university, then I was just immersed in it. But I really enjoyed it, and probably towards the end of that degree, obviously start to think about what's next. And I really found out for myself that doing working in a routine laboratory probably wasn't for me. I actually was interested in the actual experimentation side of things, and so obviously a career in research and medical research was something that I started to think about more and more. And obviously I ended up doing an honours degree fairly early straight away after my undergraduate degree, which really set me up for the next stages of my life then.
So you wanted to be more creative and come up with the ideas and then follow them through.
Yeah, I think I just liked doing experiments, having a hypothesis, or one working in an interesting field, having a hypothesis, then being able to test that hypothesis and actually coming up with some nice results or not. But there was something really logical and interesting about that process that I really enjoyed. And certainly throughout my early research days, doing my honours degree and then working as a research assistant for many years, I was exposed to a lot of different tools and technologies and techniques, which really I honed my skill set from there.
So what area did you work in when you were a research assistant?
I actually had very little to do with cancer. I actually was working a lot with stem cells and various different types of stem cells, going from those in cord blood, those in adult tissues called mesenchymal stem cells, and also embryonic stem cells. And one of my early jobs was actually looking at ways in which we could reprogram adult cells into more embryonic-like cells, because they have various properties that allow them to say, regenerate healthy tissues for the treatment of various diseases. So
that was a pretty interesting time to be working in stem cells.
Yeah, it was. There's, embryonic stem cells were discussed a lot. Obviously, a lot of ethical issues around that for good reason. And we were looking at ways of bypassing the ethical issues, but having similar opportunities available by having embryonic-like stem cells. For example, we were using it with the hope of treating Parkinson's disease. So, certainly, cord blood stem cells. One of my first jobs as a research assistant was waiting around in the maternity ward, waiting for someone to give birth, and I'd be waiting there for the placenta.
Oh wow!
So I could then go hang it up and collect cord blood from the placenta and collect and isolate the stem cells.
You weren't in the room, were you?
No, okay. I don't think that would have gone down very well.
Wouldn't have been too happy to have you waiting there.
No. There was certainly
Yeah.
Not. I didn't want to be on that side of that side of the wall. So.
All right. So that was a regular occurrence, was it?
That was a fairly
Picking
regular
up placentas.
That's right. Yeah. That was one of my earliest exposures to having anything to do with people in hospital, and but it was it was an interesting thing to do looking back at it now, but it seemed this is a tremendous source of material for our research. So.
And speaking of, you were having your own kids around that time too?
No, so actually that was probably in the early 2000s. My daughter, Alina, was born in 2010. So I was actually still a research assistant at the time. And then my son Lucas was born around 2013. So, but yeah, really up until 2012, I was working as a research assistant. And for a lot of that time, I was working with two great scientists in Professor Stan Gronthos and Professor Mark Barthold. And we were actually looking at mesenchymal stem cells within dental tissues, specifically periodontal ligament, as a way of regenerating the support tissues. Because as we age, we get gum disease and degenerative bone disease in the jaw. And we were looking at strategies to use these stem cells to actually regenerate these tissues to prevent teeth from falling out. But I had a really good exposure to lots of different projects at that time, and it was almost PhD like I felt, because I really did get the opportunity to write papers, write research grants, run experiments. I had a fair degree of autonomy at that stage of my career.
So what about that made you want to go and do a PhD?
I think that, just knowing that I could do it, that I was actually capable of having an idea and running with it, and to generate some really interesting results that have clinically relevant, outcomes.
But pursuing that when you've got kids and you've got bills to pay, isn't a decision to be taken lightly.
No.
There were some challenges around doing that.
Yeah, absolutely. And that was probably a big reason why, I probably did end up working as a research assistant for so long, was because, I did have kids, and we had a mortgage with my wife at the time as well. And obviously, when you're getting paid as a research assistant, things are quite stable, and felt relatively balanced. But obviously, there are challenges that then you need to accept when undertaking a PhD. And obviously, it's going to change your future trajectory as well, obviously for good reasons. But you really need to make sure that you want to do a PhD, that you have a plan of what you want to do with it later on, because it's not, it's a big undertaking.
So how did your wife and yourself ultimately decide that, yes, you could go and do that and that you should go and do that? Like, what was the last discussion there?
I knew deep down that I wanted to do a PhD, and my wife Lauren was all for that. She could see the benefits in doing a PhD long term. We talked about
a patient woman.
She's a very patient woman. Yeah, I wouldn't be able to do it if that wasn't for that patience, and that goes to this day. So that hasn't changed. But certainly, I think it was. We both saw that it was a great opportunity when I actually approached one of Professor Stan Gronthos's very close colleagues, Professor Andrew Zanatino, about doing a PhD, because I felt like I needed a bit of a change in terms of what I was working on. I guess the more I was involved in research, being involved in the stem cell field for a good 10 years I felt like I needed a little bit of a change in career, and so I actually went down the cancer path. And Andrew Zanatino was leading the myeloma research laboratory in the laboratory that was co-shared with Stan Gronthos. And so it was a tremendous opportunity that was presented to me by Andrew. And yeah, looking back, I guess he had the belief in me that I was capable of doing a PhD, which was really, quite a driving force for me to go, right, I think I can do this also.
Yeah. So those mentors that you respect can be really instrumental in shaping who you become. And now you're at the point where you're doing that for others, which is very cool.
Yeah.
What was it like doing a PhD while having young children?
Yeah, that was hard. Certainly wouldn't recommend it. It's certainly doable. I mean, I did it. But yeah, I guess it was never the plan for it to work out that way. It was just the way it worked out. It was just the right time for me to do a PhD was obviously when I, had kids and thought, right, I got to really make some big decisions about where I want to go in my future.
So you had to just carve out time wherever you could and reduce the sleeping and the self-care sort of.
Oh, the self-care went out the window.
Out the window, yeah.
That's right. I did my PhD for the first 4 years of my son's life, Lucas. And so, I missed out on a lot.
So you'd have him in one arm and be typing with the other.
Yeah, that wouldn't have. I probably did do that. I can't really remember that. I'm sure there were times where that happened. But yeah, I work much better when there's silence and, when people are sleeping. And, throughout my PhD and early postdoctoral career, my routine would be, you go to work, you do your standard, 9 to 5 day or whatever it is. And then when the kids go to bed, when it's quiet again by, 8:30, 9 o'clock, you're back on the computer again, and often that would be until.
Till when?
Depends how long my second wind would last. So, midnight, 1 o'clock, sometimes 2 o'clock when I was writing my thesis. But that was just, it just had to be done. But, they involved a lot of weekend work as well.
Yeah.
And obviously, I had to have a lot of support to be able to do that.
Calling in the in-laws.
Yeah. So my wife is originally from Victoria. So my parents-in-law live in Melbourne, and they were a tremendous support throughout my PhD studies because my wife's a nurse and she does shift work, and so it just would not have been possible without the support of grandparents. That includes my parents as well. And also just the understanding that my wife had that, right, this isn't forever. But yeah, it did have a tremendous impact on me because it was just, it was a massive undertaking with my with the young kids and having, I guess, my wife also working as well. So,
yeah.
But we made it work, and we're
at least you found out.
Come through the other end.
You found out everyone's there for you, and it's been worth it. And it can be done, but it's not easy.
It's not easy. Yeah. So you just got to, I guess, major when you're doing PhD later in your career, like I did. I think it's obviously there's just more things that you just have to take into consideration if you want to do a good job and set yourself up for a career in research.
And then your work in myeloma, did that just seem like it was going to be an interesting area and one that mentors like Andrew Zanatino encourage you to get into, or did you have a personal connection to cancer as well? Has that been in your family, or what was your motivation behind doing that? Yeah,
fortunately, I don't have a real personal connection to cancer, but obviously we know that we have family, friends obviously who have been affected by cancer, but at the time that didn't really come into consideration into my thought process of why I wanted to go down the cancer research pathway. It was more is recognized that it is such a major issue in society that requires lots of research to address, the day-to-day problems that people with cancer face.
And what is so challenging about myeloma in particular?
Myeloma unfortunately, it's not a nice condition to have.
To put it lightly.
To put it lightly, a lot of people don't really know what myeloma is. It's actually the second most common blood cancer, with about 3,000 new diagnoses each year in Australia. So there is a sizable number of people, who are facing this diagnosis each and every year. But it's a cancer of the type of blood cell called a plasma cell, which normally produces healthy antibodies that helps you fight infections. But what happens is that obviously these cells can mutate and they start proliferating uncontrollably in the bone marrow. And then they start spreading from one bone to the other bone via the circulation. And so effectively, when a patient is typically diagnosed, they've got lots of cancer sites, littered throughout their body. So their whole skeleton could be involved in the disease.
So tumours form?
Tumours form. And then obviously the patients are faced with the reality of what's ahead of them. Because it is a cancer that is not just in one site, surgery and radiotherapy aren't really options for most individuals. And so really what's the standard of care for myeloma treatment is a multi-drug combination strategy, high-dose drug therapy that these patients are given, often followed by stem cell transplant and then possibly consolidation therapy, maintenance therapies. Biggest problem is that almost all patients will relapse. And so obviously then they have to go through cycles of treatment again. And is it the case that each time you go into remission, the next time you relapse is often shorter? There's a shorter gap in between? Yeah, absolutely. Absolutely. So yeah, what's really evident in myeloma and, I guess in many cancers is that the better you can make the initial response to cancer treatment, the better the patient is likely to do. So there are standard of care drug combinations that patients are given, and we know that the depth of response, the level to which you can suppress or regress the tumor to that initial therapy in combination with the stem cell transplant is really critical to how a patient will do.
So that has a lot to do with governing how the cancer comes back or doesn't come back?
Yeah, well, obviously, if it doesn't work very well, if the time to relapse is short, then it suggests that you've got cancer cells there that are resistant to standard of care drugs, which obviously then makes treatment a lot more difficult because you need to then start looking at other drugs. And obviously, the more time as you relapse, I guess the more limiting the number of options there are, for patients.
So how do you summarize what you're working on to try to fix that problem?
Yeah, so I guess we, recognize that, drug or disease relapse is a major issue in myeloma. And given that the ability to be able to treat patients with optimal drugs or drug combinations and doses thereof being critical to how they're going to do long term, we realize that this needs to be, the ability to be able to treat people with optimal drugs or drug combinations needs to be prioritized. Unfortunately, what happens with this multi-drug combination strategies, these are high doses of drugs that people are given. And obviously
very damaging to the body.
Yeah, they don't obviously have just effects on cancer cells, but they also have effects on off-target tissues, healthy tissues, because these drugs don't just go to sites of cancer. And so people develop obviously side effects. of cancer therapies.
So the tolerability is not good.
No, that's right. Obviously, many people do tolerate them well, because obviously there's been, clinical trials to show that, a good proportion of patients can handle them. But unfortunately, there's still a high proportion of patients, despite it being a standard of care treatment, will develop side effects. And they can often range from something that is quite an inconvenience but something that can be managed. But obviously there's a loss of quality of life, and patients often have to accept that, okay, well, I'm willing to give this a go because I know that I need this to get my cancer under control. But other people, unfortunately, just can't tolerate the side effects.
So a big part of the aim is developing other drugs that can be used as a frontline therapy, which are more effective and better tolerated.
No, so what we're actually looking at is looking at strategies to make standard of care myeloma drugs work better or work just as effectively without inducing the side effects. And so by doing that, not only can we obviously improve quality of life, but obviously we can also allow more patients to stay on optimal drug doses so that they can actually achieve that maximum depth of response in order to maximize their long-term survival outcomes.
And what progress have you made in that?
Yeah, so when we talk about lowering side effects, we're essentially developing strategies to actually try to selectively increase drug delivery to the sites of cancer as a way of reducing drug exposure to normal tissues. And so what that can do, if you can actually get more of what the drug that you need to site of cancer, you can actually lower how much drug is actually needed to be given to a patient potentially to actually have the same therapeutic effect. But by lowering that effective dose, you can lower the off-target side effects as well. Yeah, equally, if you deliver more cancer drug to the site of cancer, you could hypothetically also increase the depth of response to the treatment as well.
And so is this a reality now, something that can be done in humans or not there yet?
No, I mean, certainly. So we've got a couple of different strategies that we're trying to do that by. And certainly there are, there is research in drug delivery strategies in cancer treatment in general. In the myeloma context, is probably in its infancy and hasn't really been utilized to the maximum of its potential. So we've got a couple of different strategies by which we're trying to do that. One is by actually modulating the tumor vasculature itself in order to make access of cancer drugs to sites of myeloma tumor more open or more amenable to getting the drug there. And we're also developing a nanoparticle-based strategy as well, which I think you probably heard a little bit about on a previous session with Christina Bursell. But yeah, nanoparticles are really they're revolutionizing many forms of cancer care, right from diagnosis and monitoring, and also cancer treatment. But obviously, again, in their novelty in the context of myeloma. But again, these are both strategies that we're looking at as a way of reducing those off-target side effects by increasing the ability of these drugs to really get to where they're critically needed and not to where they can have off-target effects.
Where do you hope we'll get to in your career?
Well, so we've got a particular interest in a drug of that's a standard of care myeloma agent called bortezomib, which is used at all stages of myeloma treatment. So we're talking about as frontline induction therapy and relapsed disease as well, both in transplant eligible and ineligible patients. Really forms a cornerstone or a backbone of treatment in myeloma around the world. And we've got some really nice data to show that some of these agents that we've developed that modify vasculature within myeloma tumors can actually increase the amount or the ability of these drugs to get to the sites of myeloma tumor and actually make these drugs work just as well, even when you're using a typically subtherapeutic dose of the drug. So we've got some fantastic proof of principle knowledge demonstrating the utility of the strategy that we're using to do that. And we're actually currently now working on investigating how that can translate to reducing side effects. So we've developed a really great model of bortezomib side effects in mice. So in patients, what the major side effects are, a major dose-limiting toxicity is peripheral neuropathy, which is a very debilitating condition affecting hands and feet. So it can be associated with sensory loss, discomfort, pain, a lack of awareness where your hands and feet are, and a generally very debilitating condition. Gastrointestinal toxicity is also another issue. And so together with Dr. Hannah Wardle, we've developed this really great model of bortezomib-induced side effects to actually look specifically at whether we can actually reduce these clinically relevant side effects in mice as a proof of principle that this might be a way that we could actually apply this technology to the real world in reducing the toxicities of bortezomib in patients with myeloma while still giving them the best chance of treating the cancer adequately.
So some promising irons in the fire there.
Yeah, absolutely. Yeah, absolutely.
And what do you do to take your mind off work? Because I'm sure your brain's constantly whirring with all of this.
Yeah, it's hard to get your mind off the job, but ultimately, I think when you do go home now and, you have kids that are at home and they need help with homework, sporting activities, driving kids around, I guess your mind does get taken off that for a bit, or getting dinner ready as well, I should say. But, I do enjoy being outdoors, sports. I love soccer. My son plays soccer. I love watching him play. My daughter does a lot of, extracurricular activities in dance and in gymnastics, which I love to watch as well. I love my fishing, hanging out with friends when I can. But yeah, I just love being outdoors and even just doing stuff in the garden, anything just to, I don't watch much TV. I'm always, just trying to, be hands-on and doing something. So
Far away from the lab.
Far away from the lab, absolutely. So, it's you need a good circuit breaker because, the research career is quite encompassing, and sometimes you just it's like when you go on a holiday, it always takes you a day or two just to kind of stop thinking about work because all the things that you left behind and still got to do, and they'll still be there when you get back.
But the flip side of that coin is there's so much purpose behind it, and there's people who are relying on people like you, which obviously comes with its level of pressure to do the work that you do, and there's a tremendous amount of meaning that comes along with that. So
yeah, absolutely.
That trade-off there, isn't it?
There is an absolute trade-off, yeah. I guess one thing that, it's really important to recognize as researchers that, yes, we are a researcher, but we work as research teams. Nothing gets done on its own. You have to collaborate. You've got to have a core group of people who are working hard on a problem, and no one's working on one problem. Everyone's working on lots of different problems, but it's about being able to fill the gaps in terms of what skill sets you need to complete a project.
We know that you're not working on it alone.
No, absolutely not. So.
Which is good because it's a big problem. They're big
exactly
problems.
Correct. Yeah. So I work in the myeloma research laboratory, based obviously at SAMRI, which is headed by Dr. Kate Van Dyke and Professor Andrew Zanatino, and they've done a fantastic job over many years of recruiting some great people into the lab.
Talking about yourself.
Well, actually, yeah, probably am, but maybe I'm the exception. So, but great students instilling a really valuable work ethic but a highly supportive and fun environment as well. Yeah, Kate, who's recently become the co-lead of the laboratory. Has Andrew led the lab and established the lab and led it for 20 years or whatever, but Kate's stepped into his shoes and has done a fantastic job in supporting the lab in a pretty difficult sort of transition time. And we have a great team. We've got some really experienced postdoctoral researchers that that I look up to, and including Kate as well. They're definitely my day-to-day mentors, and things would not be possible without their ongoing support. But also when it comes to teams, students have a big part in that as well. Where we have students who work as hard as they do and want to that share the passion for research, and that exciting result that comes with it. That's great.
That's what SAHMRI's all about.
Yeah,
Thanks,
absolutely.
Chris.
If you want to learn more about SAHMRI and the researchers working to build a brighter, healthier future for you and your family, head to samhri.org.au.